So for those of you who don't know me, my name's Damian Rose. I'm just here to very briefly introduce the Bay Area Lecture Series. So I just want to remind everybody, I think probably many of you received the email. This year we took a nomination approach. So myself, Ken Epstein, Bob Hendren, Lydia Santiago, and Gina Martinez decided that this year we would both have nominees be our speakers, as well as be very explicit about the goal of speaking to social, environmental, and racial justice. So our series this year will be in that mold. And so what I'm going to do now is just turn things over to Tanisha Clark. So Tanisha Clark is a licensed clinical social worker who recently moved to UCSF. She works in the collaborative care program at the Lakeshore Family Medicine Clinic. She earned her graduate degree in social welfare from UCLA. She's worked in multiple clinical settings. Most recently, she was a clinical care manager at the Stanford Counseling and Psychological Services Department. And her clinical interests include dialectical behavior therapy, yoga for everyone, the role of faith in the therapeutic process, and my favorite, maximizing humor. So let's welcome Tanisha Clark. She's still relatively new to UCSF, so let's get to know her a little bit, and she will introduce our speaker. Take it away, Tanisha.
Great. Thanks, Damian. Good morning and welcome, everyone. My name is Tanisha Clark, and I'm a social worker in the collaborative care program at Lakeshore. Prior to joining UCSF a year and a half ago, a little less than a year and a half ago, I had the opportunity to work with this morning's speaker at Stanford. Though our time together was short, it was very enthusiastic, and I knew I had met a very special woman who opened my eyes to many things. I was thrilled when I found out that she would be speaking with us this morning. Dr. LaWanda Hill is a licensed psychologist, consultant, and curator of spaces. She's a psychologist at the Stanford University Counseling and Psychological Services, as well as the chair of the Black Coalition at Stanford. Dr. Hill is skilled at curating therapeutic spaces and facilitating healthy dialogue to address issues central to identity. She specializes in providing culturally relevant group work, consultations, and trainings. Dr. Hill holds a BS in psychology from the historically Black Southern University and A&M College, a master's degree in professional counseling, and a PhD in counseling psychology from the University of Houston. Dr. Hill has been privileged to work in numerous clinical settings, which include private practice, university counseling, federal corrections, Veterans Administration, inpatient psychiatry, residential substance abuse treatment, and residential treatment for adolescent girls in foster care and the juvenile justice system. I have the privilege of knowing Dr. Hill professionally and personally. She is oriented to service and dedicated to lending her voice for liberation, empowerment, and advancing causes of social justice. She is a compassionate, compelling, and a dedicated clinician leader who will help to mobilize our UCSF's mission to dismantle systemic racism and combat anti-Blackness across our organization. I'd like to warmly welcome Dr. Hill to UCSF and to the Department of Psychiatry. Before I turn it over to her, just a reminder, submit any questions via the chat feature, and we will save time at the end for Dr. Hill to answer those questions. Dr. Hill, take it away.
Okay, good morning. Thank you all for having me. I'm going to go ahead and share my screen very quickly. We're going to dive into this morning's presentation. So we're going to be talking about, as you've seen from the slides, let's see here, anti-Black racism in healthcare. This is going to be a necessary paradigm shift. So I'm going to actually, a paradigm shift will require some level of deviation from the norm, deviation from thinking, deviation from what we hold to be true, deviation from what we've been socialized in, and it's more importantly, it's going to cause some discomfort. So I'm going to ask you to go ahead and center yourselves, do some deep breathing, sit with yourselves, because I'm going to invite you on an invitation for the next 50 to 60 minutes to be uncomfortable. Change only comes when we're uncomfortable. As long as we are comfortable, we are perpetuating the status quo. And what we have seen globally, and the Fed uprising is what I'm calling it. There's been a conscious raising around anti-Black racism. I know that word, those two words together may even make people uncomfortable just to hear them. So I want us to get comfortable saying anti-Black racism. I want us to get comfortable calling Black people Black as opposed to people of color. We're specifically talking about Black people. All of this is a paradigm shift. All of this is a deviation from the norm. All of this is different from how we've been conditioned. But specifically this morning, as we go down this paradigm shift, we're going to talk about anti-Black racism in healthcare and how there is a necessary paradigm shift because we all play a role in changing that. As long as our paradigms are the same, we're complicit in this system and we collectively work together to produce negative health outcomes for Black people. But once we shift this paradigm, this is not the end of the work. This is the beginning of the work. And as I go through each slide, I'm happy to revisit any of these concepts, any of these thoughts. So make certain that you put these questions in the chat, and then Tanisha's going to filter them, and then we'll have some Q&A. I'm going to try to be brief in terms of what I present so we can have some more dialogue. Okay, let's hop into it. All right, so we have a few objectives today. We're going to talk about social determinants of mental health. What are they? And subsequently, by doing so, we're going to increase our awareness of anti-Black racism and the way in which it impacts the health of Black people. Notably, we're going to shift this current conceptualization we have at risk. I hear this language all the time. Black folks are at risk for these certain comorbidities. They're at risk for negative outcomes related to COVID. They're at risk for pre-existing conditions. They're at risk for XYZ, you fill in the blank. The challenge with that at risk is that there is a narrative, there's a subtle narrative underneath that suggests that the risk is inherent within the person. Just by virtue of their Blackness or their racial identity, that makes them at risk. But I'm going to challenge you to think about the systems and the structures and the policies and the cultural norms that make us at risk. It's not an inherent, certainly there's genetic factors that we're going to talk about that we can consider, but by and large, the invisible forces, the systems, the structures that the healthcare system has been built on, that we all have been conditioned into, is what makes us at risk. As long as we hold this paradigm that inherently this subgroup of people are at risk, then we contribute to the anti-Blackness and we contribute to the negative health outcomes. So I'm going to challenge you today with that. And then in doing so, we're going to illuminate how this conceptualization leads to complicity. And complicity is what keeps this disproportionate, disparate health outcomes, negative health outcomes going. And hopefully at the end, we can begin to increase our sensitivity in assessing social determinants of mental health. Okay, so let's dive in for a second here. I want you to think about, what accounts for preventative death. We all know that health is created by the conditions of our lives. By and large, health is created by the conditions of our lives, and none of us on the call, none of us outside of the call are born into the same health conditions. A large piece of the medical model, large piece of the ways in which you've been trained or currently being trained is to focus on the medical care. That's 10% ways of which we can prevent deaths. And that's deaths related to physical health, that's death related to mental health, certainly death by suicide. Most of your focus, by and large, most of your training focuses on the medical care. But what we know to be fact is that 40% of death comes from lifestyle and behavior. Right? Our lifestyle and behavior is informed by the conditions by which we live. And we all know that there are different conditions, there are different ways in which Black people are living that contributes to their lifestyle. I use this metaphor often for people to help them kind of like visually understand what I mean by different conditions that contribute to the lifestyle and behavior. Before I use the metaphor, let's go back a little bit. Think about the narrative that you heard, right? Think about the statistics that you study. We're at risk because of the risky behaviors. We're at risk because of the social conditions. We're at risk because of our disproportionate education. We're at risk because of the neighborhoods. They're impoverished. All of this language, right, that kind of paints this idea of we are at risk because of all of these different conditions by which we're lived in. What we don't talk about is how those conditions come about, which we're going to talk a little bit more about later. How does those conditions come about? So let's just go with the original narrative before we pivot a little bit. The original narrative is we're at risk because of these conditions. So imagine healthcare and access to healthcare is at the end, because I love track and field, let's use this as a metaphor. I'm pretty sure everybody can relate to that. We're all on a track, all kind of just dispersed amongst the track. And the finish line is healthcare, right? Mental health care, just healthcare in general. Now, some of us are right at the finish line. Easy. Just go to the finish line, go across, access to healthcare. While other of us are disproportionately placed in different areas on the track. But not only are we on different areas of the track, now we have hurdles we have to overcome. And then not even do we have hurdles, because some of us don't even have the shoes to run to be able to get across the finish line. And so now we have these even more challenging conditions. We don't have the shoes. We're different places to run. We even have water to get across the finish line, to get across the track. While others are like, I don't understand why people can't just access health. I mean, it was so easy. We just ran across the track. It took me all of like 30 seconds. Well, that is by and large based on the conditions by which you have been socialized, by which you live, by which you have access to. And what we don't understand oftentimes is when we see Black folks make their way into, you know, your department of psychiatry, make their way into Stanford CAPS, or make their way into any healthcare system, by and large, they have had to overcome and jump through a number of different hurdles just to get in the door, right? Then when we get in the door, none of these factors have been considered, and we're going to talk a little bit more about what that looks like. And if we could consider these factors and have a paradigm shift, we could prevent deaths by and large. Okay, so what are social determinants of mental health, and how does this relate? These social determinants are these factors that impact us, our health and our well-being. Circumstances, where we're born, where we grow up, where we live, where we work, our age. And today we're going to specifically focus on race as the social determinant. A significant portion of our mental health is created by the conditions that we were born into, the conditions of our lives, right? We know 10% medical focus, right, that can prevent deaths, but 40% is about the conditions and by which we live. So knowing that this is our conditions by which we live that's contributing to our mental health, contributing to our health, contributing to negative or positive health outcomes, let's take a look at what it feels like to be Black in America and think about some of these conditions, right? Now, as a caveat, this is not trauma porn, right? The intention is not to invoke guilt. The intention is not to invoke shame. The intention is to invoke awareness. And if you have these emotional reactions subsequently, to use it and channel it into further learning so that we can disrupt, right? So let's just sit with this for a second. Being Black in America means it is characterized by trauma and violence more often than our white counterparts, and impacts emotional and mental health of both youth and young adults. I tell clients all the time, for Black folks, there is no post-traumatic stress. There is chronic stress. There's just moments in between the next trauma. And think about, from just a physiological standpoint, from that stress response system and how it's constantly and chronically and persistently activated, how that begins to tear down the conditions of your body, how that begins to create secondary conditions like hypertension, like high cholesterol, like, you know, stress-induced illnesses, because of the consistent trauma and the consistent violence. But that's not the narrative we hear, right? We hear that there are disproportionate rates of hypertension, there's disproportionate rates of, you know, these pre-morbid conditions, but what's contributing to them if we know that by and large, our health and well-being is based on the circumstances and the conditions. Certainly there's genetics, certainly there is, you know, biology that accounts for it, but we know a lot of this is based on the conditions by which we live. And the folks is characterized by trauma and violence. There is a historical dehumanization, right? It wasn't long ago that we were considered 3/5 human, that we were considered wild and needed to be tamed. That dehumanization, that trauma, that physical trauma, the body keeps the score, passed down generation to generation to generation, right? This historical dehumanization, this historical oppression based on what we have access to, this historical violence which is current against Black folks, have evolved into present day racism. So we eradicated, you know, the overt, you know, display of racism. But what we did was we recreated it structurally and institutionally and systematically and through biases. And then we were very strategic about creating images that perpetuate narratives, right, about Black people. They're at risk, they have these different premorbid conditions. And because of this historical dehumanization, because of these invisible forces, I call them now, it has cultivated a myriad of disparities, including inadequate access to and ineffective delivery. And that's where we're going to challenge ourselves today. Ineffective delivery. We all have been guilty of it, myself included, because of our lack of awareness of people's culture, because of our lack of awareness of the ways in which people show up differently, because of the ways we're trained, is by and large a white Western model, okay? That doesn't account for culture, that doesn't account for different racial ethnicities. Okay, so being Black in America, we have this trauma, we have this violence, we have this inadequate access, we have had ineffective, and then we have to process dealing with layers and layers of individual trauma. on top of new ones from, like, let's just say COVID, new mass traumas. COVID, we've seen the numbers. We've seen the disproportionate impact. We've seen this even outside of the sphere of medicine. We've seen the impact of jobs. We've seen the impact of evictions. We know, my mom used to use this metaphor all the time growing up, and I understand it more now as I become an adult, as I see clients come in, as I see patients at Stanford as well as in my private practice, that when white people get the cold, Black folks catch pneumonia. Sit with that. When you get a cold, when white people get a cold, Black people get pneumonia. What do we mean by that? There was already so many pre-existing vulnerabilities and comorbidities and challenges that makes the cold, maybe if you don't have these vulnerabilities, what you're going to suffer with, but we're going to suffer with pneumonia because of all of these other factors that we've been talking about. So you're talking about layers of, trauma. You have new mass traumas, you have uncertainty, loss, police brutality, the fetishization on the news media, divisive political rhetoric that adds compounding layers of complexities for individuals to responsibly manage. The stress system, as I'm sure I'm preaching to the choir, we understand is to put out a threat, right? It's activated, it's supposed to put out the threat disappears, we go back, that parasympathetic system goes back down, we're good. But what happens when you're chronically in that state of threat? Everything's a threat. No matter where you go, you're perceiving things as threat. The breakdown, the wear and tear of your body, then imagine inadequate access. And then imagine when you do have access to the system, so let's just say you choose to trust the system. There's a follow-up video that I'm going to invite you all to watch from the 1619 podcast of how the bad blood started. We all know historically, I don't remember what year it was, but medical doctors inflicted Black folks with syphilis to just see how long it would take to kill them, right? We see, not even historically, but currently there are disproportionate, the research consistently says people don't believe that Black people experience pain. They always underrate the pain. We have the highest, more deaths from childbearing labor. I've lost from this because of the negligence, because of the lack of awareness, because of the misses that we have, right? So there is an inherent distrust in the healthcare system. Now, going back to my metaphor, if you know that you have all these pre-existing conditions and you need to cross that line and enter into the healthcare system, then what does that do when you don't? It makes your conditions more pervasive, more persistent, rather than episodic. Whereas more people may experience episodic mental health conditions because they're dealing with different things, we see that this lack of access, this lack of mistrust makes the conditions more chronic, makes them more severe, makes them more challenging. For most students, for most Black students, the access of care comes in college, right? Where we have a critical moment to be able to capture them. We have a critical moment to be able to undo and be able to attend to some of these narratives and some of this mistrust, but so often we miss the mark with that, okay? So help-seeking behavior is affected by mistrust of the medical system. And then unfortunately, so what we'll see often is that Black students or Black folks or Black patients will want to go to Black providers because they understand their Black experience and they're known to give more care. But by and large, there's a very, 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 very small portion of us. And so because of this, if it's not a Black provider, because of the mistrust and because of the lack of access to care, we even talk about insurance, we take for granted that's a privilege, shouldn't be, but in this country it is, that more Black people are more likely to experience chronic and persistent rather than episodic mental health conditions. What are the treatment issues? So we know all of this. Only 2% of psychiatrists, 2% of psychologists, 4% of social workers in the United States are Black. I pause there because I don't think that that's coincidental. That's systematic, right? Then let's say, okay, I'm good. I don't need to see a Black psychiatrist. I just need to get access to health care. Then when you do, there's a lack of cultural sensitivity in care. I want you to ask yourselves for a second. Let me ask you a few questions to ponder and sit with when it comes to culture sensitivity. Now, we're historically, I know in the school of medicine, I know as counseling psychologists, we're trained with a posture of cultural humility, which suggests that there's always learning that has to be done. We never arrive. Previously, you hear a lot of cultural competency, right? Cultural competency. What does competency suggest? Competency suggests that you will arrive at a state of competence and then you're done learning, right? As if, how absurd is it to think that we can know every single thing that there is to know about every culture, about every different culture and the ways in which the nuances of it. Cultural competency is a fallacy. Culture sensitivity is the posture, right? So if I am culturally sensitive, then I am leaning in and I'm trying to learn more about the different unique circumstances that contribute to the mental health of the clients in which I see. And so I want to ask you, how many of us know about Black culture that did not rely on their source of Black culture that does not come from TV, that does not come from media, that does not come from a textbook, but comes from proximity to Blackness, from relationship to Blackness? I use this metaphor all the time as one of my good colleagues, Dr. Helen Sue, who's a psychologist at Stanford Caps, and I saw, clients were coming in, identifying as East Asian, Chinese, Taiwanese. I lost 4 clients, all East Asian, right? Cultural humility or cultural sensitivity makes me ask myself, what about this am I missing? I have to be missing some nuance of culture for me to have such a high attrition rate, right? So then I'm going to go now seek counsel. I'm going to go seek an understanding. I'm going to engage myself and expand, because clearly my level of care and the way in which I'm operating is not executable for this population, particularly when I have a higher retention rate. So how many of us do that? How many of us pause to see how many clients do we retain? How much of the culture do we understand? How much do we bring culture into the room? Because that is a huge piece of the puzzle when we're talking about mental health and we're talking about care. When we reduce to symptoms, clients will come in all the time talking about anxiety. And yes, it's a generalized anxiety disorder, or it may be MDD, and they may be in the middle of a moderate episode, but it is secondary to ongoing racial trauma. Do we have the sensitivity and the posture to be able to ask those questions, right? Do we lack those acknowledgement of those systems at place? When you have been dehumanized, at the very minimum, before we get to psychotropics, before we get to treatment, before we get to diagnostics, there's a whole separate CE on pathologizing Black people, then people want to be acknowledged for their humanity. But if that can't be acknowledged in the room, then how can we even move forward? And we're going to lose the people who were coming in who already had barriers to get there. Okay? Let's pause for a second. That's a lot of information. I want you to just sit with that for a second. Take it all in. Let's talk a little bit about the narrative shift of this at risk. We've had some historical context, right? There's a distrust. We know that there are more premorbid conditions. We know that there are negative outcomes for Black people. We have heard the dissonance won't let us sit with the reality that we play a role in it, right? The dissonance is hard for us to sit with. So instead, the usual narrative is, oh yeah, well, they're at risk, right? That means at risk means there's an outside force, there's an outside system, and I don't have any role to play in that, right? But we do. Right? That at risk is part of these systems that we're a part of. So let's take a look at the very bottom, which is the social and public policies and the social and cultural norms. I want you to draw your attention to that. The social and public policies and the social and cultural norms. So when we think about, I call them the invisible forces. They're there. We know that they're there, but we're not aware of them. And we just kind of walk into a system and we get so focused on the medicine and we get so focused on, trying to obtain that we don't recognize these other pieces. So the social and public policies are the regulations, they're the laws, they're the rules that favor some and create unequal distribution to others. We know that to be fact. They favor some. COVID has illuminated by and large. They favor some and give unequal distribution to others. Then we have the social and cultural norms, which are values, their attitudes, impressions, biases, opinions that we all have that are learned. I say this all the time. No one escapes racial conditioning. We all are a part of it. No one escapes racial conditioning. So then if no one escapes racial conditioning, then it's safe to conclude that we have all internalized some of these narratives, some of these biases, some of these opinions, some of these beliefs about what it means to be Black in America. And then specifically when those people show up in our room, when we're treating them, then that's going to inform the ways in which we engage, right? We don't focus on how we can play a role in shifting some of these social and public policies as well as some of these social and cultural norms, because we just focus on that top red, which is the poor physical, mental health, and disease. And what I say to people is when we stay there, we are treating the symptom of cancer. We're not treating the cancer. And therefore, by only focusing on this, we are perpetuating the inequity. We are perpetuating the anti-Blackness, we're perpetuating the disproportionate health outcomes. We assume the easy model. It's like, oh, this is only poor access to care, to your left here. It's only poor access to care. But if I want to challenge you a step further, if we know that there's historically a mistrust of the system and there's poor access to health, what do we do to go beyond that? What do we go to do to outreach, right? Do we challenge ourselves in our messaging, in our appeal, in our marketing, in trying to create more access? Or do we assume that everybody has a trusting relationship with the medical system, that everybody has access, that everybody will understand, and that everybody will willingly come in, right? We're going back to these social and cultural norms that perpetuate. If you have a challenge, you feel like, sure, I'm going to go to the doctor. Why not? Unless you have had a different type of experience and you have had a different type of historical and current narrative. We also reduce some of these poor health outcomes to what? Poor choices, right here in the middle. Poor choices, risky behaviors, stress. But what contributes to those things, right? Underemployment, poor education, discrimination, social inclusion, neighborhood disorder, housing instability, food insecurity, adverse early life experiences that are all being driven by distribution of opportunity. And that distribution of opportunity comes from our social and public policies and our social and cultural norms. Here is the system in a nutshell. Even when we think about the neighborhoods, right? Some neighborhoods have more pathogens, have more toxins, have more injury, they create more genetic risk. Who are likely to be in these neighborhoods? What type of access, someone asked me, kind of like unaware of these different systems, like I don't even see Whole Foods in this area. That's because it's a poor area. So if it's a poor area, there's not going to be a lot of nice or healthy options. You're gonna see a lot of fast food restaurants. You're gonna see a lot of these different restaurants and entities that are not necessarily perpetuating or promoting health, but perpetuating, low food quality options. So we talk about the poor choices, but do we talk about what the distribution of opportunity is? We focus on the red at the top, which is the poor physical and mental health and the disease and comorbidity without considering the systems that we're all operating in. But that could change. That could change today. Let's take a second and reflect on our role, right? While you read it silently, I'm gonna give you a minute to read it silently, then I'm gonna read this aloud. If you stand close to a bird cage and press your face, by the way, this is an excerpt from Marilyn Fry on the interlocking forces of oppression. She says, if you stand close to a bird cage and press your face against the wires, your perception of the bars would disappear and you would have an almost unobstructed view of the bird. If you turn your head to examine one wire of the cage closely, you would not be able to see the other wires. If you're understanding why the bird doesn't just go around a single wire and fly away, you might even assume that the bird liked or chose its place in the cage. But if you step back and took a wider view, you will begin to see that the wires come together in an interlocking system, a pattern that works to hold the bird firmly in its place. It now becomes clear that a network of mathematically related barriers surrounds the bird. Taken individually, none of the barriers would be difficult for the bird to get around, but because they interlock with each other, they thoroughly restrict the bird. While some birds may escape from the cage, most will not. And certainly those that do escape will have to navigate many barriers that birds outside the cage does not. I love this metaphor because often Black clients specifically come into our offices, we engage with them and we see them from an unobstructed view. We see them like really close to the birdcage, right? We don't challenge ourselves often to be uncomfortable to take a look outside and to be able to examine, what are these other wires and how are they contributing to the bird? And man, if they're stuck, why won't they just fly away? We don't see the different systems that are at play that's keeping it restricted. We don't ask those questions. We all play a role in these interlocking systems, right? No one person can dismantle racism, but certainly everybody collectively can. But it will require that we take a different view, that we think about the different systems, that we think about the different networks that are at play and how we're participating in them. that perpetuate this restriction, that perpetuate these mental health conditions, that perpetuate these negative health outcomes. These are some direct quotes from clients, patients, students that have shared their role in engaging with psychiatrists. We're going to take a look at that narrow view, or that view that's being informed by unconscious or conscious, biases, attitudes, beliefs, and opinions that consistently contribute to negative health outcomes. First one says, I came in for anxiety. My psychiatrist questioned if I was an affirmative action student. Why would that be relevant? What's the bias there? What's the story you might be telling yourself to ask a question about affirmative action if we're talking about anxiety? Are you suggesting that maybe you have anxiety because you don't belong here, and the only reason why you belong here is because of affirmative action? Maybe not aware of the bias in the statement, but it sounds like it's clear. These are students, these are people that I have seen who were specifically requested for a Black clinician after engaging with other, or asked for a Black psychiatrist after engaging with non-Black psychiatrists and non-Black psychologists. This has been their experience. I went in because there was blood in my urine and was prescribed birth control. I went to urgent care the next day because I had a really bad UTI. How did we miss this? What's the assumption, right? When Black females, specifically people who identify as female, what do we see in the media? What are the images? What are the lyrics? Hypersexualized Black women, right? That was one of the narratives that was used to continue to perpetuate slavery, that Black women were hypersexualized and that they enjoyed sex so much that's what made the slave masters have sex with them, justify having unconsenting sex. So that narrative be perpetuated, consciously and unconsciously. So if you have blood in your urine, you assume it must be related to sexuality, it must be related to over-sexual activity. And so I'm going to prescribe you birth control as opposed to not attend to the UTI. I had surgery, really bad surgery. I remember complaining about the pain, but was discharged with Tylenol. I was treated like I had a drug problem. What the research indicates is consistent that we underestimate the pain that Black people experience. We believe that they can experience more pain because that's been the narrative that we've seen since we were enslaved. And therefore we adopt it. And we give Tylenol when you just had surgery. We have to sit with our biases. In what ways would I approach this client differently from the ways in which approaching this client? Is it based on any of my socialization? Is it based on some of the messages that I may have internalized that may be anti-Black in nature and therefore problematic? Another, I told my provider that I was sexually active and she kept pressuring me to take birth control. I felt like she was judging me. I told my psychiatrist that I felt out of place because of racism on campus, and she sat in silence in response to my experience. I was later diagnosed with depression from a different psychiatrist. The first completely missed it. If we never confront these narratives, if we never confront these biases, how then will we be prepared to address them when they show up in our offices? And then how many diagnoses will we miss because we can't lean into that cultural sensitivity? How often do we prioritize our comfort at the expense of our patients, of our clients, because of our lack of awareness about their experience? Last one, it was summer and I didn't live near campus. I rode the bus for 2 hours one way, only to have my appointment canceled and told to plan better. I see this in the charts all the time. Student was non-compliant, 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 non-compliant. But why? Why were they non-compliant? One of the things that I learned after losing 4 patients, when consulting with my colleague, is that a lot of my East Asian clients had not been introduced to therapy. So I'm in my clear role of assessment, and I'm trying to assess for symptoms, and I'm using words that they have never ever heard of. And I could have said they're non-treatment compliant, they're not motivated, they're ambivalent about change. Or maybe it's my posture, maybe it's my approach, maybe it's something that I'm missing and I'm not understanding. Perhaps this client, if this last quote was not non-treatment compliant, or that they just were late, perhaps they had other obstacles to overcome to be able to get through the door. And then when they get through the door, there's not consideration of the different factors. So there's a moment for us to pause and ask ourselves, what role have I played? What biases do I hold? In what ways am I actively seeking to undo those and examine those? Because we, fool ourselves if we believe that we are not operating out of conditioning, out of racial conditioning. One of the things I want to invite you all to take a follow-up look at, and I'll try to post this in the chat, it's the 1619 podcast, How the Bad Blood Started. It gives a really good historical backdrop of the beginning of inequity. And the response often from folks who are unaware is like, well, that was years ago, and that was several years ago. But when you have had several years of inequity and there's been no conscious efforts or no substantial efforts to counteract that, then we're still dealing with inequity. So we just inherited all that we were living 400 something years ago. And when we don't acknowledge those invisible forces, because some of us don't have to acknowledge those invisible forces because it's not our reality, then we are perpetuating this system of inequity. We're perpetuating this system of inequity of anti-Blackness, and we're operating in it. And it is notorious in healthcare. Notorious and runs rampant. So before we move to the Q&A, I want to invite you to just sit with your reactions, all that may have come up. And think about all the content. If it is a posture of defense, you may have missed the point. If it is a posture of curiosity, of humility, of exploration, then we welcome those questions. If at any point in time somebody gives me some information that I am unaware about and I immediately want to defend it, then I know I'm probably operating out of my fragility. I'm operating out of defense of a point as opposed to leaning into somebody else's reality. So I'm going to invite you to lean into that discomfort, because that is the precipice of change, and then we can engage in a Q&A.
Tell me when you're ready, LaWanda. I have some questions. Okay.
Thank you, Nicholas. All right, ready when you are.
Okay. This is a great question for Brett. She works in collaborative care. She's one of our new interns. So she was discussing, your discussion was about treatment ethos across departments. She's wondering how epigenetic trauma and like mind-body racism as type 3 trauma, how is that considered in the care of Black folks? Black people, thinking about things like linking hypertension and diabetes to weight rather than a history of chronic stress. So I would imagine, like, how are we breaking that down to effectively treat people? How does the larger trauma, like, trickle down so that maybe Black people are at higher risk of hypertension, diabetes? How do we work towards treating those differences?
Medically or in the context of therapy?
Probably. I think this is medically. I think in therapy, well, what would you say in therapy? I could see how the two join forces as a collaborative care worker. That would be the therapist consulting with a primary care doctor and making sure we're discussing the cultural issues and the societal issues that you discussed at play. And I think also educating patients about, I work with several African-American women, and I don't think they don't all understand that hypertension is hereditary among a lot of African-American people. And so we do some psycho-ed that's very helpful for them. And I think remembering those things is helpful. I don't know if you have anything to add in therapy.
Yeah, I think in therapy, I think it's important to understand from an epigenetics perspective, we know that like we are passed down these genes, right? And they can be activated, right? They could be activated within certain environments that we're lived in. Those vulnerabilities can certainly, from the environmental stress, be activated, which then let's think about learned behavior and conditioning, and then what we have access to, and then being on a chronic state of stress, how do we deal with that? How do we accurately deal with that? I know for some that's eating, for some that's engaging in pleasure, and eating the things that may or may not be best for us, that usually are high in sodium. Historically, as an aside, when Black folks were enslaved, they would get what we call the slops, like the seconds, not the hearty things. And so that was usually pork, was usually salty, it was usually all of the bad stuff that you then continue to eat. And we are a very tribal, cultural, collectivist community. So you gather over these historically meals that have been high in salt, you know, not necessarily high in nutrition, not high in the things that we need, and we gather around and it becomes part of the norm. And so these epigenetics, right, in addition to like cultural and ways in which we gather, because we had to create some level of resistance, some level of joy amid pain and enslavement, we created it around food. So it becomes very near and dear to the culture. And so after this, then we like, okay, now we have these different foods that we're eating, plus the epigenetics, plus the vulnerability, plus the lack of education. And then now here we have a medical condition. I think all of those things have to be considered in the ways in which things manifest, but we often stop at that top piece, right? That tip of the iceberg, which is just, oh, it's, you know, they're at risk, so it is what it is. What are these other functions? What are these other factors? What generationally has been passed down, both from a gene perspective as well as culture and norms that are operating, that's creating that, that the manifestation of that premorbid condition.
All right, thank you. Another great question from Damien. Struck by the implications of calling people at risk. We do it all the time with reference to adolescents and young adults at risk for quote unquote serious mental illness, and worry which biases inform who I think is most at risk. I'm wondering what a better term is. I'm wondering what a better term might be, or maybe we should have more specific and have several different terms that don't lump everyone into a group with a presumed shared trait.
That's a really great question. I don't even know if it's about like a new term as if it's about a paradigm shift in the conceptualization, right? Like immediately if I'm thinking about, if I'm treating a Black client, I'm thinking, okay, what are some of the challenges that they may be systematically, maybe that's a good different term. What challenges are they systematically facing that's contributing to the anxiety right now, or that's contributing to their presentation right now, or is contributing to what I feel like they may be more vulnerable towards? What are the policies? What are some of the norms that could be contributing to that, thus placing them at risk? So I think the language, you know, when we begin to shift that paradigm, we shift that language, which then helps us start to think about them differently as not inherently the client. Sure. It is these systems, and how am I going to attend to that? What may be something that I may want to initiate, or outreach or programming that I want to do to kind of shift that perspective. So I think that maybe asking the question or using the language, what systems are at place, what kinds of challenges, what types of barriers is this client facing, these students facing, these adolescents facing, that make them more likely to experience that X, Y, Z that I'm treating.
Okay, thank you. Considering vulnerabilities, let's see, Monica Sanchez, what is the best way to systematically examine the bias and assess for cultural humility for providers in our system? Good question.
Always, 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 always start with self-reflection and awareness. Always. So often I see this, it frustrates me a little bit because it's so trending now, you know, to be, and I hope that that's not you all, but it's trending now to be anti-racist. It's trending to be actively working to dismantle anti-Blackness, but this has been a part of the work I feel like born into. I'm from the heart of the South, so I was born into all of that. And so one of the things that helped is my own self-awareness about what biases I hold, what ways in which I am participating in white supremacy or perpetuating these norms, or I have been colonized in my thought, because so quickly we want to hear and then go to action. And I think the best action is to do self-reflection, because an unaware person is a dangerous person, very, very dangerous, because they're busy trying, I see it all the time. So many instances this has occurred at Stanford as well, where clients have come in like, oh my God, my professor, the department decided that they were going to call a town hall and they just wanted to hear all about Black people's trauma, and then open them up to trauma. And they have literally shared things like it just felt like fetishizing, like, oh my God, and then to appease their own guilt, and not knowing how to appropriately handle when people are talking about racial trauma. There was no follow-up. There was no other skilled clinician in the place. And so that came from a lack of awareness and just a quick, okay, I feel guilty, I want to get rid of it, so I want to go do something, right? That is about your experience and not the other. So I think that the first step is self-awareness. There's so many different resources, there's so many different books, and expose yourself to different cultures. My good colleague that I'm talking about, Dr. Sue, I remember one of my first impressions of her was seeing her with a badge from the Association of Black Psychologists, and she identifies as Taiwanese. And so I was like, hey, is that an AB Psi badge? She's like, yeah, like I go to different conferences so that I can learn about different people, different cultures. And I thought that was like, whoa, why am I not at these conferences? Learning, engaging, because proximity to Blackness doesn't mean that you understand Black culture and understand Black experience. And people use that. Everybody's heard the people, I got a Black friend, so I'm not racist. Proximity doesn't make you have lived experience, and it certainly doesn't exempt you from biases. And so I think a good first step is self-awareness, self-reflection, leaning into different cultures, exposing yourself, and being uncomfortable. Being lonely and being uncomfortable.
Okay, thank you. This is from Eileen Diamond. You mentioned clients not having been introduced to therapy. Can you say more about what this means, and what have you found to be effective ways of introducing clients to therapy?
Well, I think what I mean by this is we have to take for granted that, start with the fact that our therapeutic system, all of the modalities that we have been trained in, at least from a psychologist perspective, is from white men, from a Western approach, right? Who, in this American culture, that is a very white dominant, we know that to be fact, we know that to be true, despite how uncomfortable it makes us feel, comes from that approach. I think about my international students that I see who are not socialized in talk therapy, who don't understand what it means to be depressed, or do not understand that the purpose is to come in, talk about your challenges, share your symptoms so that you can be diagnosed. We're so indoctrinated with that modality, we believe that everybody else is, and that's just not the case. And it's certainly the case for these international students I was talking about. So when I lost 4 of them, when they didn't come back, and I talked with Dr. Sue, she was like, well, you have to remember that this is their first time. They don't really know what to expect. And they're really probably sometimes looking for you to just tell them what to do. So my question, what's been most effective to me was like, is this your first time in treatment? Is this your first time in therapy? I'm curious, have you heard about it? What were you expecting? What were you hoping for today? Based on that answer, I may do some more education. I may take it slowly. It requires that we deviate from our traditional assessment process. Sometimes I don't go straight into, are you experiencing X, Y, Zs? They don't even have the language sometimes. So I use much more of a conversational, much more of a rapport building approach, and then throw some of the questions in to assess, because I have to remember that just because I've been socialized in American culture and this Western approach to treatment, it doesn't mean that everybody else has.
Okay, agreed. I like that. Also does a lot, the psychoed, my experience and observation is that it helps to dispel stigma also, and provide reassurance to people about the process they're starting. Okay, Sandra, this is Sandra's question. How can providers integrate resilience and strength-based frameworks in tandem to this important foundation? So integrating resilience and strength-based approaches.
I think I want to start with, we have to first challenge our paradigm of resilience, because that is I think resilience only works if there's adequate recovery. And certain things we should not have to be resilient through, okay? So I think part of the battle is understanding what paradigm to resilience are we even taking. Resilience that just push through, have to endure, have to overcome. I hear that model, I see it in some notes that I audit, I am utterly disappointed by it, because certain things we shouldn't have to be resilient through. So I feel like one of the key things that I do for clients, particularly Black clients, because there is these different stereotypes of the strong Black woman who is perceived as invulnerable and not needing any rest, but can push through and carry everything, is to remind them that resilience works to the extent that we have adequate recovery, to the extent that we're able to disengage from the chronic stressors, to the extent that we're able to actively see what we need to be able to recover, and then we could be resilient. And that strength may be in community. That strength may be in engaging in artistry. That strength may be in advocacy, right? But using the reality that, again, narratives get co-opted, and we use at risk the same way we use resilient, not all of us, but some of us, we use that narrative to perpetuate, Black people having to endure, having to experience these things without getting adequate justice to their humanity and things that they need to do to kind of self-select out of some of these things. So there's an article that I'm happy to send along that I use often, but I think that's a good first start, is to think about what conceptualization of resilience do we even have, and is that rooted in a stereotype about Black people that we are resilient.
Thank you. These questions are great. Next one from Maga Jackson. Trish, sorry if I mispronounced your name. I also think it's important to acknowledge that the Black community is quite diverse, even with the common experience of racial trauma. Absolutely.
We're not monolithic.
Right, correct. And I think that can also come, if I can add, like psychoeducation, like people from the South versus people that have Afro-Caribbean histories, maybe Black people from Canada, just understanding the differences.
Which is why I will underscore the importance of cultural humility. I think that's a really, really good point. I am a person from the South. I have friends who are from Afro-Caribbean descent, people who are from Canada. We all have different nuances to our cultures, and it's not a one-size-fits-all. Not like the cultural competency model that we've seen taught in school about Black people are this, X, Y, Z. So we have to challenge that paradigm.
Okay. This next one is from Alex Acosta. Thank you so much, Dr. Hill. How do you respond to non-Black people of color, especially colleagues, that attempt to derail your arguments and de-center Black folks? Anti-Black sentiment is unfortunately common in the non-Black Latinx community, and I sometimes struggle to respond to these distractors from my own community. Great question.
How do I respond? I'm radical, so I usually just name that. Like I really name that. I really challenge them. Like I really feel like what's coming up, and I ask a lot of process comments. It's my approach to treatment. I'm interpersonally oriented, emotion focused in my work. So my question is to like name the process. Like I feel like we're decentering the conversation right now. Like what's coming up for you that's so hard to sit with this right now that we have to decenter? That by centering this narrative right now, that means you're taking away from your own. That's not the case. So what I believe it comes from anti-Black sentiment, and it's certainly in POCs, the POC community and the Black community, frankly. But I think I name it, and I am at a place in my life at this juncture that I can't engage with that. It's just too much chronic stress. I can't engage in that conversation unless people are willing to actually do the work to be able to address the fact that could it be that you too have anti-Black sentiment, given that we were socialized in this nation around that. So I hope that helps. I'm really about interpersonally sharing what I'm experiencing in this moment, asking thoughtful questions, asking people to pause and really be able to reflect on what they're saying. That's very passionate sometimes. Sometimes it's very passive, but it is about naming it and disrupting it and figuring out, I have to honor my humanity and my experience, and I can do that by sharing how I'm experiencing you right now.
Okay, thank you. Ooh, I like this next question from Aubrey Harrison. Do you have suggestions, strategies to help providers explore and learn about clients' cultures outside of the media, textbooks, etc.?
Yes, there's so many. Now, certainly, first I would ask you to invite clients. Like I would ask the clients in the room. Now it's nuanced. You don't want the client to do emotional labor and school you on their experience. But if you have a client who's Black, and you're non-Black, and you have never addressed race in the room, I want to invite you to do that in your next encounter because it's in the room. The process is always happening whether we choose to acknowledge it or not. And lean into it, like, hey, I realize I've never really acknowledged this. Find a way. You don't have to start the session with it, but find a way to acknowledge it because it's certainly in the room. That's number one. Number two, I think when you do that, why am I encouraging you to do that? When you do that, you invite people, you allow people to invite you into their experience and you let them know that you care. They hear, okay, you care about my experience. My experience with my psychologist when I was at the University of Houston, our most pivotal moment when she, as a white woman, and I was talking about my chronic stress as a Black woman, said, what is it like to say that to me as a white woman? Open up the door for treatment. As opposed to her pretending like it wasn't in the room and not, or like she could understand, that created more rapport. So, and that invited her into my experience to learn from me, because remember, we're not monolithic. There's so many different narratives of who we are. I have subscribed so many documentaries, which I'm happy to provide a follow-up list to. There's so many documentaries. I love I Am Not Your Negro by James Baldwin. I love so many Black films. I love the nuances of culture. None of them come readily to me, but I would say like, certainly it's dramatized, right? And certain films and books maybe even perpetuate some of the negative stereotypes of Black folks, but it's just an exposure to culture. You can see a lot of the nuances of different types of culture in different film, from talking to different people, from going to different fests that celebrate Blackness, going to different conferences that celebrate Blackness. There you would have people showing up, sharing their stories from their mouths and not from film. So I think that there are several different ways. We have to always remember the caveat that we're not monolithic. Some things may be dramatized, but especially when we talk about film, but in that you can catch some reality of the culture.
Okay, that's great. We'd like some articles about the resilience. So maybe if you can post that, send that to Andrew, that would be great. Also, thanks about decolonizing the resilience framework. Thank you. And this, Peter from Santa Rosa, this is, I'll read the question and let me read it through it. These are very deep issues. Yes, understand. How do these issues accord with busy clinic schedules, like, right, less time for assessments, fewer barriers for prescribing antidepressants versus counseling, social issues masquerading as DSM-5 issues. These are similar issues to those faced in community mental health care when you know someone needs stable housing, but what you have available is a once-a-month long-acting injectable. How do we imagine the very systems of care, right? Which is a very big question. I don't know how you want to tackle that.
I have a simple answer to it. It's a complex question, but I have a simple answer to it. I think the reality of it is that we have to make the time. We have to, even if it's 5, 10, 15, 20 minutes, we have to make the time to be able to get outside and reimagine, because if we don't, we'll stay caught up in the same system. I use this metaphor all the time. You know, Stanford is, everybody knows about Stanford. And one of my colleagues said one time, she said, you know what, it's amazing to me, LaWanda, that we sit in meetings for 6, 12 months sometimes strategizing about how to raise money. Just taking the time, strategizing about how to raise money. And that those problems, those multi-million-dollar, billion-dollar projects never seem too enormous for us to make the time to do. Like, no, despite everything that's going on that we talked about. But somehow we start talking about dismantling these issues or tackling these issues that it feels just it just feels too big and we can't do it. We can make the time for what we find to be important and prioritize. And it's certainly not without challenges, trust me. But I think when we think about how we're not all charged with fixing every single problem, but we certainly have a role in a problem to fix. And if I do my role and you do your role and you do your role and you do the work you need, then we can dismantle that. If we think about it like this big, gigantic thing that we can't overcome and get so caught up in the hardness of it and the difficulty of it and the time restraints, then the system will just stay. But when we make the intention of like, okay, I need to learn about this culture, I need to engage, I need to challenge myself, then that's what makes the difference.
I love that answer. It kind of spoke to, as you saw my response, as evidenced by my response to that question, like, this is so insurmountable. Thank you for that. Okay, 2 more questions. Here's one. One's a comment from Damian Rose. I'm pretty convinced that the assumptions the DSM-5 makes about mental illness as inside the individual serve to perpetuate systemic bias and hide healthcare's role in inequity.
Absolutely.
Or Damian, yes,
absolutely.
We agree with that. Julie Jacobs, thank you so much for sharing, Dr. Hill. I'm wondering if you have best practices for naming and recognizing experiences of racial trauma and systemic oppression in formal documentation, particularly in diagnosis and treatment plans that will inform future treatment with other practitioners. Great question.
Best practices. I use the language of trauma, and I put a label, a specifier on it. Client reports hypervigilance, difficulty trusting, preoccupation with negative things subsequent to being Black in a predominantly white space. They've experienced it for a persistent amount of time. This appears to be racial trauma. I'll move forward accordingly, right? I think we documented it. We are very uncomfortable with putting Black in front of things, y'all. We're very uncomfortable with that. And we're uncomfortable with calling something race-induced. I think we've got to get beyond that. So best practice to me is to name it. Best practice is always to name it and conceptualize it within that framework. I have said major depression persistent subsequent to microaggressions in a predominantly white male lab. That is what's a significant portion. The environment, epigenetics, is causing the manifestation of this vulnerability to depression. It's creating a moderate episode. But when I ask them what are their identifiable stressors, these are the identifiable stressors. Naming it, creating a documentation or a paper trail of it. We are complicit with the system when we don't not name it, when we continue to put it on the person and not name what the environment. And it's okay. We all contribute to people's distress. I'm certainly sure I have. but the accountability is what invites us to change, as opposed to like not acknowledging that accountability.
I like that, documenting it. And I like your additions, the details. It's the details, right?
Mm-hmm.
There's no V code for being Black and oppressed, but we can definitely, yeah, and we can definitely specify it in the assessment. That is our final question. So many great questions. Thank you, everybody. I think you have the podcast or the link to the article in there, and then the article for the resilience, decolonizing resilience. Maybe we can get that sent out. That would be great. I think that's it. It's 9:30. Our time is up. Thank you so much. It was a pleasure. There's one new message. Oh, that's it. I think we're done. Right, Damien? That's it. Okay. Thank you so much. And big thanks to you, Dr. Hill. Everybody have a great day.